Hi, it's Heather, and I'm so glad you're here. We've renamed our podcast Health, Harmony, and Heather to reflect my passion for enriching our perspectives on life by exploring social phenomena, the human condition, and our abilities to connect with ourselves, each other, and the planet. We'll talk about all forms of health, from the physical, mental, and spiritual, and we'll hear from experts that take us closer to living harmoniously. We will explore all things that lead us to our innermost truth, happiness, and freedom. Join me and take the ride. My next guest, Lauren Rosenberg, is a highly experienced physician associate who's dedicated 2 decades to internal medicine and health optimization. Driven by her passion for preventative care, Lauren founded Vent Health to shift the focus from disease treatment to prevention. She specializes in a personalized approach to her care that blends genetics, epigenetics, biomarkers, and lifestyle factors to tailor health interventions that extend and optimize each individual patient's health span. Today, Lauren is here to talk with me all about menopause, the truth and the science of it, and all of our solutions. And I'm so grateful to have her here and back with us. Welcome, Lauren.
Thanks so much for having me. I'm so happy to be here. I'm excited to be back with you.
Well, I love, for you who treat me and I've really changed my life and my experiences through not only menopause, but other pro-aging situations we go through. I love having you on to share all the things that you share with me, with my audience and viewers. And menopause has been a subject that, has been on my lips for a long time, since my first sign of perimenopause many years ago. And I don't know why, but people are still afraid to talk about it. And I think that's changing, thank goodness, where women are starting to talk to each other about it. But these days of women suffering silently, they're over, girl. And we need to bring it out to the forefront that we do change, that our bodies are evolutionary and we go through changes as we age. So I want to dive right in. And I want to dive right in with one of the things that you said to me once, which I really stuck with me. And I think it's a really good way to explain it. You say that menopause is really just one day. And that is the one day that you haven't had your period for 12 months. It's 12 months goes by, and that's the day that you're like, wow, I haven't had my period for 12 months. Prior to that one day is what's called perimenopause. And post to that one day is postmenopause. And these are all signifying changes in hormones. So take it away, Lauren, and go off of that. I love that genius, kind of little quip there.
Yeah, so you're exactly right. So everyone talks about, I'm in menopause. Well, are you at that 365-day mark? Because if you're not, you're probably in postmenopause. And so when we talk about these terms of where we're at, early in your life, after you reach puberty and you're having normal cycles, we call that menopause. Then you have perimenopause. And perimenopause is this stage of life, which could be months to years before you hit that menopausal state. And so menopause, as you mentioned, is one day of life. And it's after not having a cycle for a full year. So 12 months of not having a cycle, you have a party, it's menopause, you've reached this next stage of life where you can thrive. And we just need to know all of the things that we're going to discuss today. And every day after that one day is considered postmenopause. And generally, when people talk about symptoms that occur when they're in perimenopause or postmenopause, it's because of this erratic fluctuation in hormones that happens in perimenopause. And then after you stop cycling, after you stop releasing an egg, which is the full purpose of having cycles, is to procreate, your body has this dramatic drop in estrogen. And that leads to a number of symptoms that occur after you stop having your menstrual cycles.
So let's get into the overall science of it for a second. The hormones, the symptoms, which hormones do we need? Why do some people like me really struggle, through the post-menopause process, and for me, it was perimenopause too, leading up to that one day. And then afterwards, I mean, it's kind of a 10-year process at the end of the day. It's not just over in a night. But some people can, I want to say, power through it, or some people go through postmenopause without a lot of symptoms or without a lot of interference, and they don't seek out help. They think that I think they're few and far between personally, but they're out there for sure. And, a lot of like my mother's age will be like, well, we just powered through it. And again, those days are over, because I want to talk about what's happening in the body and then what are those symptoms. And because you're my girl, we talk about root causes. We talk about the why this is happening before we talk about the treatment of what to do. So get into the science of it a little bit more, the hormones, the symptoms.
Absolutely. So before we enter perimenopause, we have normal cycles. And again, the whole goal is to release an egg from the ovary so that it hopefully gets fertilized and we can make beautiful babies, as we have actually done. And so when we think about the hormones that occur during this kind of life cycle, is we have usually a normal menstrual cycle is 28 days, give or take. Everyone is a little bit different. But in the first half of a cycle, so day one is the day that you bleed. So you're shedding your lining, you're bleeding. And at that point, all of your hormones are low. And throughout this part of the process, you're slowly building up estrogen. You're slowly building up FSH, follicular stimulating hormone, which is coming from the pituitary gland. So a lot of ovulation, everything is actually driven from the brain to signal the ovaries to make follicles and to release an egg. And so we talk about estrogen being dominant in the first half of the cycle. Your FSH builds to build follicles. And then you have this surge. You have this surge of something called luteinizing hormone, which is LH. We think of that at that 14-day midpoint. Sometimes you can think of that kind of like, if you can remember back to when you were cycling, you get kind of this thick, like clear discharge, you're ovulating, and it signals that egg to be released. And then once the egg is released, you have something called a corpus luteum, and that makes progesterone. And so in our second half of the cycle, progesterone takes over. So the uterine lining has been built up by estrogen in the first half. Progesterone takes over in the second half. It's considered calming. It can really, really help you. If you fertilize and you make an embryo, then it helps with the pregnancy process. It makes that lining stable for this, baby to thrive in. And if you don't have an egg that is fertilized, at that point, your progesterone drops off, your hormones all drop off, and you start the process all over again. And it's this nice, like beautiful rhythm of having the same thing that occurs month in and month out. Now, when we get into perimenopause, we get into these years leading up to where you're running out of eggs. So let's talk about that part. You're born with a finite amount of eggs, maybe 1 million, 2 million. You have the most when you're in utero, and then you lose some through a process called atresia. And then you lose some through every cycle. You're losing every single cycle. So if you're born with 1 to 2 million eggs, by the time we're 30, we have about 10% of those eggs left. And by the time we're 40, we probably have 3% or less. Some people will actually go into perimenopause sooner. Mm-hmm. And so as your body is not making enough eggs, or the quality of the eggs aren't as good, the ovarian signal doesn't respond to your brain. So your brain wants estrogen. Your ovaries say, we don't have enough good eggs. We can't really respond to this. Your brain says, give me more estrogen, and keeps firing these two hormones, FSH and LH. And finally, your body responds with this influx of estrogen. So not what you would typically make. It might be a more erratic form of the estrogen. It might be much higher than you would typically make in your normal cycles. But then instead of falling back to where you're used to, you fall lower in this kind of like chaotic roller coaster. Some people will call it a zone of chaos, but it's really just this roller coaster of you're going to be here, you're going to be here. You don't know where you're coming. You might cycle, you may not cycle. You may have periods that are close together. They may be far apart, but everything is erratic in this time of perimenopause. And then once menopause hits, You just have no hormones. They really, I mean, you can produce very, very little from the adrenals that sit on top of the kidneys, but you're really making, a very, very little amount. And then that leads to other symptoms. But what I would say is perimenopause, some people do kind of skate by. It's a very small percentage and subset of individuals that probably don't experience anything or they're not really sure. But most people just don't talk about it. They, and you said your mother. I mean, most of my mom too, you just deal with it. And maybe that's because of the stigma of hormones. Maybe that's just because we were taught that we need to be tough and fight through it. But we need to talk about it because
maybe there was because there were much bigger number of male doctors.
Perhaps
my mother's, age growing up,
blow you off.
They have no idea or whatever. So this is so, I love all this. You're so good at explaining things. So let's talk about the symptoms. Let's clue people in that maybe think they're in perimenopause or know that they've had that one day and 12 months has gone by and they are not having their cycle anymore. And they're definitely in postmenopause. Let's talk about some of the symptoms. And there are so many. And like you said, some people experience, like I experienced in perimenopause, like crazy hot flashes. And I didn't know it was happening because I was under a great deal of stress when it was happening for me, which I'm sure can also help kick it off. We can talk a little bit about that, where you are in life when these things are happening. But the hot flashes for me were crazy. Then they stopped. Then they're like hot flashes I never got again once in a while. And then then the brain fog came, the day after my one day, then it was brain fog. Now everybody's different. And some people have a multitude of symptoms. And then later in the menopause cycle, something else showed up. And so it doesn't all necessarily come at once. Sometimes they do come at once. How do people know what's happening? How can we give them a little hand holding that, you're probably post or you're probably perimenopause?
So I think the first thing that we need to know is that the average age of menopause is around 51, give or take. Certain, ethnicities will go through it sooner. Some will go a little bit later. And you can experience symptoms leading up to there 10 years in advance. So it may be months in advance, but it's usually somewhere like 4 to 10 years. You can start to develop this erratic flow in hormones, and it can lead to these symptoms. And you don't have to have all of them. You may just have a few. And it becomes really hard to discern what's going on because, like you said, like you're probably in the prime of your career. You may have children that are starting school or leaving for college, and your business may have blown up to a point where there's a lot of, chefs in the kitchen. I don't know. There's a lot of things going on. And so people don't know to think, oh, this may be my hormones because they may still be cycling. And so you think that if you have a menstrual period that you don't need to think about these things. So the most common things are the hot flashes, which you mentioned. You could be talking to me and all of a sudden break out in, sweating.
You have to take off clothes, literally.
Yeah, you want to take it off. And then you may get the
everyone
chill.
says, I'm having a hot flash.
Yeah. And it literally happens like that. I haven't experienced it, but I've talked to someone where you could actually see it happening. And I know it's happening because you can see the sweat bubbles come up.
Yes.
And then the same thing can happen in the middle of the night. So we call that, night sweats. So that's kind of what most people think about as your menopause symptoms, but it can cause brain fog. It can cause joint pain. There's a syndrome of what we call frozen shoulder. It's adhesive capsulitis. So what encapsulates the shoulder actually gets adhesions and people cannot move their shoulder. That's more rare. But then we get sleep disturbances. So even if you don't get hot flashes, you're just not going to have a nice, like deep sleep. Yeah. Anxiety is through the roof, or even depression. And we think that's a lot because when you go into perimenopause, sometimes you can have something called anovulatory cycles, which means you're bleeding, but you're not actually having that ovulation. And if you don't ovulate, if you don't release that egg, you don't make the progesterone. You don't make that corpus luteum to make the progesterone. And so when you have these people will talk about estrogen dominance, but really it's probably more of a progesterone deficiency than an estrogen dominance. It's just an imbalance.
Mhm.
And so progesterone is so important for relaxation. So your sleep gets worse, you get more kind of PMS or anxiety or depression. So that's what's happening. You may notice a lack of libido or vaginal dryness. So estrogen helps with the mucosal lining. It helps to lubricate things down there. And so when you have this lack of estrogen, things start to dry up. The elasticity, the connective tissue down there is not great. And so if you're losing elasticity there, that's why we also see skin aging later in life, because you have this lack of estrogen. And we'll talk about how some people are using estrogen on their face now because it helps with collagen production. You have pain with intercourse. So even if you're not having that decrease in libido, you have pain, or you're having a decrease in libido. And then when you decide to do it because you love your partner, you want to make them happy, it hurts. And then you don't want to do it again. There's joint pains, there's headaches, there's fatigue, there's brain fog. I mean, literally, there is a list. Ringing in the ears, vertigo. I'm trying to think of all of the things because
Heart palpitations. That was what I had.
Yes, you get palpitations, and we can talk about all of the effects on heart with the change in hormones. You can have an increase in your bad cholesterol called LDL, lowering of your HDL, which is your good cholesterol. You can have a rise in your blood pressure. You can have changes in visceral fat. So there's weight gain that it comes, and you start to see it as this central obesity. It's that harmful fat that builds up around the organs. So not necessarily, we don't love the subcutaneous fat, but it's not metabolically active. It's not harmful, but that inner abdominal fat is what builds up. So it increases by over 20% once you have this change in hormones. And that can lead to cardiovascular disease and fatty liver disease and diabetes, dry, itching skin. I mean, the list goes on. I can probably run off of a few. UTIs. UTIs is a huge one. Because again, of that loss of mucosal lining. And sometimes if we just give you vaginal estrogen, you no longer have dryness, you no longer have pain with sex, you no longer have this overactive bladder, right? So estrogen receptors are everywhere. So it affects everything in the pelvic floor region. So it makes you have to pee all the time. You can't hold your bladder anymore. We have a very resilient body. Think about when you birth the child, everything goes back, maybe not technically how it was pre-birth, but it's, you don't have this anymore because you don't have the estrogen.
Right. So this is such a wealth of knowledge. And I just want to back up for people and just go through some of the symptoms. So, I was in my late 30s, early 40s when perimenopause started for me. And again, I was under a really stressful situation. And so I didn't recognize it for what it was. Mm-hmm. So you guys, I just want to run through the symptoms. So the hot flashes we've all heard about, right? Heart palpitations, I talked to, the brain fog, lack of libido, if your ears are itchy or if your skin is itchy, anxiety, trouble sleeping, weight gain around the midsection, changes in your hair. That's one that we didn't talk about but that I have listed. Changes in your hair and skin because you're using that elastin from the estrogen, urinary tract infections. So what I want to remind everybody is, doesn't this sound like your grandmother? Doesn't this sound like middle age? They call it middle age. Middle age is when everybody starts to look older. You gain weight in your midsection. Everybody kind of turns into a meatball. You don't sleep. You always hear people who are aging focusing on loss of sleep. And so, while our moms powered through it, our grandmothers powered through it, they lost a lot of traction in what I call pro-aging and what you call vitality and life in your 50s and beyond, true longevity. So,
Well, what I was going to say is, number one, you mentioned the hair thinning. And if we think about a pregnant woman, their hair is voluptuous. I mean, it grows so much because there's so much estrogen. And if you think about menopause, I was thinking about it today, and it's almost like postpartum. You go from having, and it's a little bit different because when you're pregnant, your levels are through the roof and then they drop down. But it's like going postpartum all over again, except you never recover. So, but we can recover. And the
Yes.
reason why it's so important, you're talking about your grandparents, and maybe people didn't have the knowledge and the access that we have today. And we'll get into the Women's Health Initiative and how, we had so many women that were on birth control, and then all of a sudden, everyone just, ceased taking it because there was kind of this misinformation that even when it was debunked, no one really let everyone know.
Right.
But the reason why it's so important is because estrogen is vital for your heart. It's vital for your bone density. It's vital for your brain. It's vital for your metabolic functioning. And when you have this drop, it's why people get cardiovascular disease, which is the number one killer. It kills more people than all cancers combined and becomes the number one killer for women after menopause. Bone density will lead women for heart fracture. They'll get bone fractures. They fracture their hips, their spines, and their wrists. And estrogen can easily be utilized and is FDA approved for osteopenia and osteoporosis as a preventative mechanism so that you don't end up in the hospital. Because once you lose your ability to walk and care for yourself, you lose that dependence. That's when everything goes downhill. And then we're tying out Alzheimer's to estrogen loss. We know that more women get Alzheimer's and dementia than men. And we outlive our counterparts. Men die before us, but we are living that last half of our life or that last third of our life in an unhealthy capacity. And if women knew all of this information, they can make informed decisions as to whether or not this is something that works for them.
Yeah. I mean, estrogen truly is that lost fountain of youth.
Yeah.
And, we are living longer. It's not like God messed up and people are like, well, why does, our maker make us stop making estrogen and we're supposed to go through this? We're living so much longer than we used to. And so I want longevity with vitality.
Yeah.
And so I don't want to be shriveled up like a prune in a wheelchair in my last years of my life. I want to be running a marathon if I want to, and
Yeah.
And so bone health and bone density and joint pain, you mentioned, how many people do you know out there who's had a knee replacement? Over 50, 60, it's like they do them a dime a dozen. I'm keeping my knees. And I can, and I'm because I'm trying to get out in front of it. And that's really what we're talking about here. So we talked about some of the symptoms. Let's talk about some of the solutions, because we talked about the root cause, why these things are happening. But let's get into what forms the hormones come in, how you can get them, and what's important to get. Because, we have testosterone in us too as women, and men also have estrogen, and it counts on both sides. So why don't you tell us a little bit about the forms that hormones can come in and how you can take them and dose them?
Absolutely. So the most common, hormones that we're talking about when we talk about this process, I really talked about estrogen and progesterone, but you just brought up testosterone, which is one of my favorite hormones. And for all of these, men make all of these hormones just like women do, just in, different amounts, right? So they make a lot of testosterone. We make a little bit less, but we actually make a lot of testosterone, and that's important for us. But these hormones come in oral formulations, topical formulations, patches, vaginal suppositories, and rings. And each one is a little bit better in different forms. So when we talk about estrogen, I generally use transdermal or topical applications, and I tend to stick with bioidentical formulation. So bioidentical means that it's identical to what your body naturally produces. I apologize for that. That's Ryder. You've seen Ryder.
That's okay. We love a little kid around.
We're going to close that door. That's my attack Bernedoodle.
That's the dog.
That's my. So estrogen, I usually will use a transdermal application, or I will use a patch. And both of those are great. A patch you can get from your regular pharmacy. It gives you a nice steady dose, or you can apply a topical variation that you get from a compound pharmacy.
Let's go back to bioidentical for a second versus a pest. So bioidentical, and that's what I take. That's what I'm on.
Yeah.
What it does is you take your blood, always take your blood, because I've been to a doctor who was just going to put me on a patch without even taking my blood. You want to take your blood, and so you can see where your levels are, right? Like, where is my progesterone? Where is my estriol? Where is my testosterone? Like, what do my levels look like? And a bioidentical fills in the gaps, right? It says where you should be. Is that a good way to put it? Or is it just what the natural dose would be? Because you can play with it a little.
So first of all, everyone should always get their blood done. I'm and it should be an advanced panel, because when you can't just look at hormones in a nutshell, like we can't practice in silos. We need to look at the full picture, because thyroid gets dysregulated. Yes. Your vitamin D and iron and B12 and your lipid particles get dysregulated. So when we're thinking about this stage of life, and even before, I like to get a baseline look at everything that's going on in your system. And we'll talk about how the lipid particles, they actually think that they're going to be able to use small LDL particles, which I monitor in everyone, to assess someone transitioning in the perimenopausal stage, because it goes up. Now, when you get blood work in this perimenopausal phase, or anything prior to menopause, it's a little bit hard to get an accuracy of where you stand, because estradiol is fluctuating. Right. So, if someone has a normal menstrual cycle, I usually tell them to, if it's a regular 28-day cycle, blood work on day 21, because if you have high progesterone, we know that you've ovulated. If we're looking for like premature ovarian failure, we'll look in days 1 through 3, because if you have a climbing FSH at that time, it signals us that you might be, transitioning into this perimenopause or menopausal phase. Once you're in menopause, it doesn't matter where you look at it, because they're constantly low. Right. Testosterone doesn't really change that much throughout the cycle. There might be like little, changes here and there, but it's more steady than the other hormones. So you should always get a baseline, especially when you're in menopause, because I like to know where you are to see if it explains the symptoms. And we never want to give you a super therapeutic dose of anything. So when we're doing estrogen, we're not trying to get you back to where you were when you were cycling. We're trying to give you a minimal effective dose to relieve your symptoms, whether that be the hot flashes or the vaginal pain or the joint pains or the energy. And so it's a much smaller amount than you would have been given to prevent ovulation. So birth control, which is a synthetic hormone in much higher doses. When you get bioidenticals, you're getting something similar to what you naturally make in a very, very low dose. And then we guide it. I never want your estrogen levels to be 200 when you're in menopause. But if you're at 50 and we've now relieved your symptoms, that's a good start. Some people might need to be at a level of 60 to be there, and some people at a level of 40 might have full relief. And so that's where we're monitoring. We're making sure that your liver is looking good. And then I like to monitor testosterone, because I love testosterone. I love it in perimenopause. I love it in postmenopause. It supports bone density and it supports your muscle mass. And for a lot of people that have transitioned into using GLPs, which we both love.
Yeah, we're going to talk about those peptides.
It supports muscle loss. So we don't want to lose muscle when we're losing everything. So if you don't use it, you lose it. Right. And if you don't have enough testosterone on board, you can't build it or make it or sustain it. So testosterone is another topical formulation that I use a lot. Now, these all come in pellets. I'm not a fan of pellets. Mm-hmm. That doesn't mean that, women can't use it and it's not great. It just, if you don't like it, you're stuck with it for a long period of time. Right. And sometimes the doses are really, really elevated. We can really adjust things, work with you. If you're noticing you have acne, we can lower the dose. If, your hot flashes are still occurring, we can increase the dose of all of these. Right. And so I really like to work with the topicals and the patches.
So for the listeners, a pellet is something that they do Star Trek style, I call it, and they shoot it into your butt usually. And that pellet, think about it, Lauren was saying how the doses could be very high. So think about the pellet when it's all full and formed and it's really high, everything's really high, but then it starts to melt within your body and it gets smaller, right? And it eventually melts away and you need another one. So think about the doses. It's like an Alka-Seltzer tablet. Think about that in the cup of water, but it's not staying in the cup of water. It's going throughout your system. So the dose is higher on the front end and not quite as robust on the back end with a pellet. So bioidentical or topical is something that they can measure to bring your levels up. A patch, I thought, couldn't be bioidentical. Has that changed?
Yeah, so the patches we consider as like a bioidentical solution.
Right.
And so those are really easy to apply on you. I still like working with the creams, but there are some people that they just get a steadier state with a patch. And so, it's easier for them and then they don't have to apply it every single day.
Is the patch not a one size fits all though? Like, does everybody who gets, there are different doses. Okay. Yes. That's really great. I'm talking now 10 years ago when I first started this, maybe more, I went to my gynecologist who happened to be a male who had delivered my children. And when it came to me saying, listen, I'm having these symptoms, he's like, I'm putting you on the patch. I'm putting you on the same thing my mom's on. And I remember he never took my blood and I never put the patch on my body. That's when I actually got in touch with you. And I was like, this doesn't feel right. So the thing about the patch is I want to talk a little bit just for a second, pragmatics on insurance and not insurance. So most gynecologists understand hormone replacement therapy. That's what we're talking here. HRT, hormone replacement. Most of them, hope.
Do they?
I know is the question. Well, what they might do is know that it's an option and they can prescribe a patch and slap it on your body just like their mother. Yeah. Or they're really well versed like you are in it. So I think one of the things you want to do is go, and some of this is covered under insurance. And some things are things that you have to come out of pocket for. So like my progesterone is covered by insurance, but my bioidentical hormones are not. But for 100-day supply, it cost me like $100 and something bucks. So it's not, for me, it's my key to life, but I just want to give them a little bit of an idea if they're going into their own gynecologist, then of course we're going to let them know how they can, contact you to work with you the same way I do. But just give a little background on what the three are and kind of what seems to be covered and what you can ask for when you go into your gyno.
So first of all, I want to say, and I didn't mean that in a condescending way, but in school, I didn't learn anything about hormones or hormone replacement. You probably get one lecture. And I think the same things happen in med school. And we actually have some really, amazing doctors and women going out on social media platforms to get the information out there to make sure that people are getting trained more in this and they know more about it. Mary Claire Haver she was just actually on Oprah. She's amazing and she is getting the word out there.
I was going to say Oprah has to open up her stage in order for it to be a megaphone of awareness when there's these pockets like people like you that have been doing this for decades.
Yeah. And so I think that what happens is because most people don't get the training, they don't always feel comfortable to prescribe. And then you have the Women's Health Initiative, which was this landmark study that, looked at thousands and thousands, at one point over 100,000 women. And they stopped it early because they said there was an increased risk of something. You went from 40% of women being treated with hormones to none. Right. And if we look at the amount of women on hormones today, it's somewhere between like 4 and 7%. So, people just don't feel comfortable enough. And it's a shame because these are life-saving hormones, right? They prevent you from cardiovascular disease, Alzheimer's, fractures, mental health issues. Yes. Like women are leaving their jobs. Yes. People are leaving their jobs in midlife or having increased suicidal ideation because of a lot of these hormonal changes. And so it's as simple as asking your doctor if these can help you. If you have these symptoms, there are insurance-based bioidenticals that you can use. So for women, it is a patch, like the Vivel dot patch, and you can start really low dose. If I have a younger woman who's having surgically induced menopause, we start them at the highest dose because they're at an earlier stage in their life. But for, women in menopause,
Someone who's had a hysterectomy, for
yeah,
example.
correct. You can go up. Now, so that is kind of estrogen. And then estrogen, you can also get a ring. The ring is a little bit more expensive. The other form of estrogen that we use that is not systemic, meaning it doesn't get into your blood, but is really great for the vaginal canal, is a suppository. So like Vagifem or Uvafem. And it's an estrogen suppository. And so even for people with, breast cancer, they can actually use that because it's just working on the local tissue to help stimulate collagen, help with lubrication, help with pain, help with that urinary incontinence. And that can be helpful. And that is covered by insurance.
That's good, you guys. I just want to people who, because breast cancer, a lot of people are like, oh, I've had breast cancer, I can't go on estrogen. So, and I want to take away the misnomer about that, back to the Women's Health Initiative that you talked about. When they dropped people off of hormone replacement therapy is because they found, I don't want to speak for the whole initiative, but I know, and you can clue me in if I'm wrong, they found a high result of women who were on estrogen getting estrogen-induced breast cancer. But that was because the estrogen that they were using was from horses. They were using way too high doses of estrogen. So it's something, can you speak to that a little bit?
Yeah. So what they found, first of all, it was not statistically significant. And the way that they gave the information made everyone, stop prescribing, stop taking. So actually what they found in the estrogen arm only, so women that were just taking estrogen, and keep in mind, if you take estrogen and you have a uterus, you need to take progesterone to protect the lining, okay? So if you've had a hysterectomy that has removed your uterus, then you don't need to take progesterone, but it still has benefits. So I still use it in a lot of those patients.
Yes.
But in the estrogen only arm, they actually had a protective benefit against breast cancer. They actually saw less breast cancer in those patients. We also know that women that are on estrogen therapy and hormone therapy prior to breast cancer diagnosis have better outcomes and die less. So I think that's really important to know. Now, in the estrogen plus progestin, not progesterone arm, they were using these synthetic hormones. So they were using conjugated, horse urine. It came from mares, so Premarin. And then they were using progestin. And in that arm, they saw a slightly increased incidence of breast cancer. Now, there was no increased deaths. And I may get these numbers a little bit, mixed up, but I believe it was like 5 out of 1,000 had breast cancer in the hormone arm, and 4 out of 1,000 had breast cancer in the placebo arm. So in 10,000 women, there were only 8 more cases, no more deaths. And when we look at absolute risk versus relative risk, there was no increased risk that was so statistically significant that the study ever should have been stopped.
Right.
And even though, we didn't have social media back then, but this was the headline that made everyone close up shop and say, we're never using this again. The other things I want to say about the study is that they had the started, average age of women were in their 60s. I think it was 63. And most women go through menopause at 51. And there is an optimal window of starting these hormones. So you can start at perimenopause, and you're at your best if you start these hormones within this 10-year window of your last menstrual cycle. That's when we know you have the most cardiovascular benefit. After that, I would want to make sure that you don't have any soft plaques in your heart that could potentially rupture. And we can get more into that. But if you start within this window, you're great. But because they started later on, they potentially saw more increased risk of strokes or heart attacks. And again, it was very little. It was in women that probably already had disease because they were older and they weren't bioidentical. And we know that when you're taking something that is similar to what you naturally make, you're in a better position. I always actually try to use the example of, you don't see, 20-year-old men and women walking around with, maybe now a little bit more on the breast cancer because we're seeing more of an incidence, but age is the biggest risk factor.
Right.
So men are not walking around with prostate cancer when their testosterone is the highest in their 20s. They're getting it when they're in their 70s and their testosterone is the lowest. And the same thing is happening for breast cancer. You're not getting it when you're really young because of high estrogen. You're getting it when you're older. And so we don't necessarily think that estrogen is the cause. And we do have a lot of women that are coming out now, and they're really speaking to the point that even if you have cancer, you should probably take estrogen, and it's probably protective for you. I don't want to get into that on here, but there's just so many health benefits.
Right.
Yeah.
Right. So this was amazing. So you guys, there's so much misinformation out there. Ask the questions. And this is just a reminder to get your yearly mammogram, stay on top of those boobers, keep the pictures coming. And when you stay on top of that, that's prevention. You're always going to get out in front of things, you know? And so I just wanted to say that there is a lot of misinformation out there. So if you're feeling some of these symptoms, if you are perimenopause and you're going through symptoms, but you're still cycling, if you're at that one day where 12 months has passed by and now you're in perimenopause, you're in the perfect window for treatment to go talk about what your options are. When is it too late, Lauren?
So I wanted to just go back and touch on the other hormones we didn't talk about.
Yes,
so we
for sure.
Estrogen. So progesterone, micronized progesterone, which is called prometrium, you can also get through insurance. So you're taking that, you mentioned.
Yes.
And that works on GABA receptors. It's so amazing for sleep. If you're having sleep disturbances, it's amazing. If you go on estrogen, you need to be on it anyways if you have that uterus. Yeah. But it really helps a lot with the sleeping, and it helps a lot with the anxiety and the stress. So progesterone is really calming. We love that. Get that through insurance. And then testosterone, I tend to stick with compound pharmacies because I can tell you the dose. It's not FDA approved for women, but it helps with the bone density, the muscle mass, the energy, the libido. And some doctors are prescribing like an androgel or a testim, and then you kind of have to take a pea-sized amount and you don't know how much you're getting, which is why I like to use a compound pharmacy. So I can tell you the dose and then, you know, increase it. But there are ways of like drawing it up in a syringe and administering it and knowing your dose. But those are the three formulations. I like to use that one topical as well.
Okay, good. So I get my I have my estradiol, my progesterone, my testosterone and my estrogen all in a topical form. And then I take the progesterone at night, at sleep time, and with my magnesium. And I sleep beautifully. I want everybody to know 55, just turned 55, and I sleep.
You don't look it. You don't look a day
That's
over
because of my
40.
estrogen, all this estrogen that I get. Okay. So we went through the hormones. Just answer the question about when is it too late? When is it too late?
It's never too late.
Never too late. That's what I thought.
It's never too late. And it's never too early to talk about it, to learn about it, to understand your risk, to talk about your family history. Because again, if your mom had osteoporosis,
yes.
I want you getting a bone density scan now. I don't care if you're 30.
That was so important.
Yeah. I recently had a 39-year-old with, almost osteoporosis. And if we went by criteria, she wouldn't be tested until she was 65. Right. We need to know it's never too late. And even if we think, okay, we don't want to start estrogen because you're 75, I may send you for a scan to look in your arteries. And if there's no plaque that's there, so soft plaque, calcium, things like that, then you're a candidate. It's when I don't know if there's soft plaque, then I would be a little apprehensive to start it. But otherwise, you can still take the localized estrogen. And I have women that call me and they're like, I've been peeing in my pants and wearing a pad, and I could have used this all of this time and no one told me.
Right. That would help with incontinence.
You can start at any time. Testosterone, you can start at any time. So it's really never too late.
So guys, going into your own doctors, again, one of the things that I've talked about on this podcast before is you have to learn to be your own advocate. The days of you doctor, me patient are over, and you have to advocate for yourself and talk to them about how you're feeling and what's going on and know what to ask for. So, the day perimenopause for sure, but the day that you hit menopause, that one day that 12 months went by, that's a marker to get a bone density test. Then you can have a baseline to know that right? I mean, you'd probably want it before that, but for me, that's like for sure. Once you're not menstruating anymore, go get a bone density test so that you understand what your baseline is. So to back up, we talked about the hormones. We talked name the hormones that we need, and what we just want to go through it because we broke up in the middle of it a little bit.
Okay, so the hormones that we really need are estrogen in the form of estradiol. Testosterone is really amazing. If you're on estrogen with a uterus, you absolutely need progesterone, so micronized progesterone. If you don't have a uterus, you have the option not to take it. And then those are kind of the mainstays: estrogen, progesterone, and then testosterone. And then looking at all of your other levels to make sure that your thyroid is good, that your vitamins are good, that you're exercising and putting on the protein
and eating properly. Exactly. So you should be doing your doctor. And then remember, the hormones come in bioidenticals. They come in patches. They come in pellets, which we don't love, but maybe it's better than nothing if it's a place that you have to start. But there's also the patch is always an option anywhere you get the pellet. First of all, nobody wants to admit that, their sex life isn't robust and perfect. I mean, most people know that as you age and you go through marriage, things change, and people want to say, oh, we're still having great sex. But the truth of the matter is you're not. Yeah. It hurts. You don't have as much of a sex drive as you used to have. And these are things that can be helped and treated, and they don't have to be, swept under the carpet. Yeah. And I think it's important to talk about. I want to tell you about another girlfriend who I had for Passover, who was not herself all weekend. And I was just like, what's going on? She's like, I can't think. She was literally in post-menopause hell. She was falling apart at the seams in front of me. And so I got her on the peptide protocol website. First of all, one of her biggest issues, the brain fog and the libido and all those things came out. But she has this weight that she has this like 20-pound weight gain around her stomach, and it's visceral fat. It's not subcutaneous. I mean, this is visceral fat. That's what grows around your organs. That's what's really scary. And she feels bad about herself. She can't understand why and she's working out like a demon, and she's eating like a precious princess, and she's getting literally nowhere. And she just day by day feeling worse and worse and worse. So the first thing I said to her is, I'm going to put you on this website so you can start to, educate yourself about peptides. But you've got to then tomorrow go make an appointment with your gynecologist and talk about hormone replacement therapy. It is an option for you that you have to talk about. And peptides are amazing, but coupled with hormone replacement therapy, it's life changing.
Of course. It's so important to be coupled together, because you might be able to help the weight loss, but if you don't help the bone density, then you're going to trip and fall and break. And so you really want to couple them together. And if you're catching someone, I have so many people that come to me, and again, I told you they're in their 70s. It was never talked about. We have to kind of tiptoe around, is this safe for you? Let's get all of these tests to know if we can start you. But if you're in this window of you're just going through it, I don't need to get all of those tests. I mean, I want to get them anyways for prevention, but we can start you right away. Yes. And then we know that insulin resistance, or your sensitivity to insulin, which is a fat storing hormone, decreases as you go through this transition. And so when that happens, you accumulate more fat, and your sugar and your metabolism is all over the place. And so people that might have been skinny their whole life, all of a sudden say, I didn't change the way I eat. I'm still working out. I'm working out harder, and I can't get it off. And we love GLPs pre, peri, and post menopause. And when they're coupled with the hormones, they can work wonders, because sometimes just starting the hormones is not necessarily going to make that weight drop off, but you can start to, again, benefit your heart and your bones and everything else, because the GLPs are protective for your heart. They're protective against insulin resistance, or they can help to reverse it, prevent diabetes. They help with inflammation, and inflammation markers increase in menopause. So I can't speak.
And inflammation is the number one cause of most chronic diseases, as we all know, because you've listened to my podcast before. Yeah. So all of this is a math equation. It's 1 + 1 = and it's like, we need to, and we are educating. It's important to educate the men so that they understand, but most important that we educate the women more. That's why I have you on, to get this information out there. So yeah, your practice includes prescribing peptides. I've had you on before to talk about GLPs and talk about the difference between Ozempic and Wegovy and what a GLP-1 is and weight loss and et cetera. But so the GLPs we know help with really starting that harder weight to lose, redistribution of body fat, right? I've heard you say about that. They help the heart. You say they help diabetes, insulin. But now there's already a newer generation of GLPs that I've been reading about. Retired. Are you proud of me? Because I have to keep up. They're fascinating to me. These are amino acids and the building blocks, right, of proteins. And so these scientists and these biochemists are looking about lowering the harmful fat around the organs. And so this retired is a new GLP-1 that has other G numbers in it that you're going to remind me what they are, but helping to improve your metabolism, helping reduce that inflammation that we know is a killer. So talk about this one, CJC epimorelin, what I went on to help my tissue repair. I know there's BPC 157 I read about. There's a PT 141, which helps libido.
Yes.
And all of them can be done in microdoses. One that I just got in, which I'm really excited to try, which I'm going to have on our update call with you down the road when we're not podcasting, but we're client patienting. Is the GHKCU, which has got copper in it, which is helping promote that elasticity that you talk about, the soft tissue healing, promoting collagen and elastin. Yeah, you guys, whole body collagen, elastin. So, around the fat around your knees, you know what I mean? In your face and down there, girls. That's right. Yeah. So let's talk about these GLPs. Let's talk about these peptides and how adding them even before you go to get your hormone replacement therapy, because you can get that sometimes faster than going to your gyno and understanding it, but the combination of them all and how important it is as an option.
Peptides, as you mentioned, they're amino acids. They're small little proteins, and they all have different benefits. So the newest GLP on the market is triple threat. It's a GLP, a GIP, and glucagon, I believe, is the last G in it. And I believe it's going to blow the other two out of the water. So as you know, Ozempic has been my baby since like 2017 when it was released. And then in 2022, tirzepatide came out, and the results were phenomenal, not only in weight loss, but in reduction of diabetes. And then we just had better weight loss and less side effects.
And also reduction of habits, right? Food chatter, like it was really good for people.
Noise, alcohol noise, like addiction noise, because it works on the hypothalamus, which is your craving center. And then we expect, again, because it's not released to the market yet, that retired is going to have even further benefits. And where this really is helpful for me is I have some clients that they just plateau. We reach a certain point and they can't get any lower. And so that either means that I have to tie in other medications, which I don't love because they're not physiologic. Physiologic meaning like your body doesn't naturally produce them. Or now I have another alternative. So I went from Ozempic to switching to tirzepatide when people plateaued or they had side effects. So I'm excited for the people that, we can't get their diabetes down, or they've lost, 94 pounds, but we still have another 50 to go, of being able to turn to something new and see how we can layer it in. And then we're always layering and stacking other peptides, because you mentioned a few of them. So when we talk about CJC epimorelin, it's like a growth hormone analog. So it can really help with building muscle as long as you're working the muscle.
Yeah, you got to work out on that one. That's not one you sit on the couch with.
I mean, apparently there is one you can sit on the couch with, not a peptide, urolithin A. I actually love it.
Yes, I had it on my podcast.
I take it. I know.
Yes, I take it too. It's really great.
That actually is one where they saw benefits in muscle growth, even without
when you weren't changing your workout. Yes. Yeah, on the CJC epimorelin in my Pilates class, I just added a blue. I added a red, or added one more weight when I was doing the squats, because I had lost fat, but I had also lost muscle. And so that helped me rebuild my muscle. But more than anything, it helped me repair my tissue.
Yeah, so
That was
it's
really
really, really great. So it helps with stem cell production. So we use it in injuries. We use it before people are going to go get like PRP or stem cells because it can help them build their own. And then when we layer on something like a BPC 157 body protection compound, I think that's what it stands for. It's because it really does protect. So it can help with the lining of the intestine. So we use it in IBD and ulcerative colitis and Crohn's, but I use it for all acute injuries. And really, if you take it together, it has a benefit long term. Like you can consistently take them together. But if someone gets an injury and they're not on it, I'm like, get your BPC 157 now,
right.
and you need to start it. And sometimes we add in something called thymosin beta 4 or TB 500. But there's certain ones that you can't take chronically. Like I don't want you taking TB4, TB 500 without taking breaks. You need to take a medication vacation on some of these.
Even, yeah, the
Yeah.
CJC Epimorelin, I was like 5 days on, 2 days off.
Yeah.
And then I only did it for a few months and then I was done with it.
Yeah.
And then I do give my body a rest. And now,
Yeah.
on our call that we have coming up,
Yeah.
I'm going to be ramping up some new peptides
Yeah.
for like the GHCKCU, which is
Yeah.
for hair and nails and skin.
So, and great. So that's a great one that you can take. You can take it as an injection. I actually have it in a topical formulation with estriol. So like an estrogen formulation and tretinoin and vitamin C for the face. When you take an injection, it helps systemically all over. But again, I don't want people injecting copper all the time. So you can do it for like a month, and then you take a medication vacation. And we do these cycles. So, for people that go onto these websites, it's amazing that we have access to it, but you want to make sure that you know what you're doing because do no harm is the most important thing.
Right. And also some of these are growth hormones. So you want to know what your baseline blood is, or if you have cancer in your body or anything like that. We talked about this. So your doctor is the way, but your doctor very well, most likely is not versed in these things. And so because they're amino acids, you don't necessarily need a prescription for them, but you need a compound pharmacist a lot for them. But you also want to have a doctor overseeing your entire whole body and everything that you're doing, right?
Correct. Yeah.
Pretty true.
So a lot of them were going through compound pharmacies and were, taken away by the FDA. I think most of it has something to do with big pharma. So you mentioned PT141. I've used it for men and women for hypoactive sexual disorder. We talked about estrogen and vasodilation. So now you have a lack of that. You don't have the circulation and the blood flow you need down there, just like men need blood flow to get an erection.
Yeah, and they have Viagra.
Yeah. But you can actually use Viagra too in topical formulation or in low dose Cialis. I use it in women and it's good for the heart and it's good for overall like vasodilation everywhere. So that's something
really great. So that's something else you can ask your doctor. If you don't have access to the peptide, these are ways around it and ways through it. Yeah. And you can also show them when you do have access. I mean, they're everywhere now. I see them advertised on TV, which makes me happy. Like Him and Hers has it. Noom has it, which is a weight loss app. They're around. And obviously Dr. Lauren has them and you can reach them through her, which we're going to get to at the end. But none of this should be a secret. That's the whole idea of this. It's not a secret. And I want to let people know that, yes, they can get these directly from you. There's places to learn about them. There's ways that they can fill up their own noggins with the right questions and go into your doctor's office armed and loaded with your good health and your longevity in the holster.
Yeah.
And, and fire the questions off, I mean, I do feel bad for doctors today. They are burdened with paperwork and they have, very small amounts of window, but you're their patient and you've got to force the time that you need to get the answers that you want.
Yes. So I think that the issue is that most medicine practice under insurance guidelines is a volume business. Unfortunately, it's a broken system. And we weren't taught about hormones and we certainly weren't taught about peptides. And so it becomes really hard to go into your doctor and say, I want this. And they're like, I don't know anything about this. I'm not going to give it to you. So there are, just like you're not going to go into your primary care doctor and say like, I'm having a heart attack, treat me right now. You're not going to go to them probably to say, I need this. Some of them are going to be open. They're going to want to learn and they're going to bring it into their own practice. And for those that aren't, you may want to work with a longevity specialist or a biohacking, clinic. There's a lot of places that are really getting into this and just making sure that they're knowledgeable about it, that they're willing to follow you. And you're your own best advocate. So learn about it, read about it. We have the ability, there's so many websites now, there's social media where you can learn. And of course, you'll get a lot of opinions. You have a lot of great like AI-based tools that you can ask questions to. And I've looked at them and they do give really amazing information. It's actually scary how good it is sometimes.
Yeah.
So use them because they're free tools and resources that you can learn, and then you can work with someone that's knowledgeable and educated in it that can help to guide you, but at least you have a background.
Yeah, 100%. I think that that's most important. So again, you guys, just to go through, there's topical gels, bioidentical, there's creams, there's patches, there's pellets, that's for hormones. And we talked about peptides and use Chat GPT, ask about peptides that are good and hot topics for menopause. You can go to these sites and look for it and then ask your doctor. But what else can we do at home? What are some of the other important things? Like I had mentioned magnesium, that are kind of like non-starters for women who are peri-post or menopausal today.
So get your labs checked because most women need vitamin D, and you always need to take it with a source of vitamin K to make sure you channel vitamin D and calcium into the bones and not into the heart. But levels of like 60 to 90 are considered optimal for not only bone density, but immune system, cancer prevention, and just overall like energy, hair, teeth, nails, feeling well. Making sure that you're doing strength training and building that muscle is so important. So muscle is your organ of longevity. It's kind of like where all of your metabolic function resides. And so in order to build muscle, you need to work it. So you need to be doing whatever you can as far as like lifting weights. And then you can tie in certain things like creatine monohydrate is really wonderful for brain health, for your metabolism, and for building muscle if you're using the muscle. I love for women in menopause to consume lots of fiber. Fiber is so important for cardiovascular health, just to feel well. So you want to get, close to probably like 30 to 35 grams of fiber a day. Healthy fiber. So getting it from like your fruits, your vegetables, your avocados, and your seeds is really, really great sources. Zone 2 training. So that's that breathy heart rate. So you can walk and talk. You might be a little bit breathless. It's usually probably a heart rate around 120. Doing that for 30 minutes, 3 to 5 times a week is great for vasodilation of the heart, is really great. Meditating is wonderful. Doing any types of balance exercises is amazing because it helps with kind of bone density. Anything that works on grip strength, because grip strength is an overall proxy to how strong the rest of your body is. But also, when we lose our balance and we trip and fall, we brace ourselves with our hands. And so sometimes you see the wrists are the first places to get fractures. So anything like carrying groceries works on it, but lifting weights does it. Doing something called farmer's carries where you're holding heavy weights and either standing there, walking around, or lifting your legs. Hanging from a barbell, like when I take my kids to the park, I hang from the monkey bars, or now I've tried to start doing pull-ups, but anything where you're using your grip strength is going to help you overall. It's a longevity measurement. Drinking your water, making sure that you're consuming enough. Protein grams. If you want to weigh 120 pounds, you should aim to eat 120 grams of protein a day. And so, most of the recommendations on how much protein you should intake is to sustain life, but not to thrive through life. And so more protein is going to help you keep that muscle, which is going to protect your bones. And then just working with someone that's really kind of educated. And then I talked about that urolithin A, which I think is great for cellular energy, for muscle strength. I really love it because they did a lot of they put their own money into the research, and it's really the only supplement that has backed research on it. And it showed that you actually could prevent sarcopenia or build muscle in sarcopenic patients, so age-related muscle loss patients, by just taking the supplement. So if you took that and actually worked out, you're going to have better benefits overall. Yeah. And then, I mean, looking at the whole picture, like if there's Alzheimer's risk, you want to make sure that you're doing some type of high intensity interval training, because it increases something called BDNF, which is fertilizer for the brain. You want to really limit sugars. I mean, that's a huge thing. Anything processed, refined sugars are going to be terrible for you. It gets worse as you age. So if you can minimize that, it's great overall for menopause. It's really important for brain health because we call it Alzheimer's type 3 diabetes. And then you really also want to increase omegas in the diet. So making sure chia seeds, flax seeds, hemp seeds, salmon, sardines are really great places. They're lubrication for your joints, but they're great for the heart. They're great for the brain. So it's really about kind of getting this like whole system approach of looking at everything. It's hard to just say one. And then I have most women on methylated B vitamins because most people have a variant in a gene called MTHFR, and then they can't absorb B vitamins, and then they build up something called homocysteine, which is detrimental to brain and to heart. So again, it's about looking at that entire picture, making sure that you're kind of optimizing each thing. And, you know, at the very least, a healthy, whole, balanced diet of, you know, sticking to that kind of Mediterranean is really great. A keto flex diet is really good because it limits the sugars, but you know, don't take those packaged foods. They're not going to be great for you.
Exactly.
Also live life and less to no alcohol, because I really find that alcohol in, you know, after menopause, alcohol just doesn't sit well. It affects sleep. It's never been good. It's, you know, toxic, but it really does disrupt the sleep patterns afterwards. And so, you know, women tend to say like, I used to like it, or I used to be able to tolerate it and sleep through the night, but now it just doesn't sit well with me.
Right. They can't metabolize it. They're waking up at 3 o'clock in the morning. And also a lot of these drinks have tons of refined sugar in them. So it's just causing inflammation. You know, we talk about that, like after a stressful day at the office, like we've been conditioned to go home and crack a beer or open a wine. And what you really need is a green juice.
Yeah. You need like a sauna, a PEMF mat, and like a meditation app.
Exactly. Exactly. And speaking of that, another great supplement that they could maybe add to the list for some of that anxiety, the heart palpitations, would be ashwagandha.
Ashwagandha, L-theanine is also wonderful. There's so many great things. I mean, you know, lion's mane is great for brain health, but ashwagandha is wonderful. Like it's really, really great.
So you guys, so much information in this podcast, but I hope that we're opening these doors up to more research for yourself. I mean, if we went backwards and you're having these symptoms, start with the supplements over the counter that you can buy that, you know, Lauren just went through, from your vitamins, and get your blood tested. You know, my girlfriend that I was out with last night, she had her blood drawn. She has no vitamin B in her system whatsoever. So much so that they had her get injections once a week of vitamin B to bring up her levels. So I take a subcutaneous vitamin B shot every 3 months. And then I also take liposomal B, which is all the B's. You know, they turn your food into energy B vitamins. They're perfect. Vitamin D, we talked about that. That's a must-have for anybody who's in the menopause world and aging. And we talked about magnesium.
Magnesium. Oh, I love magnesium. So magnesium is vital for probably about 500 processes in the body. And, you know, when we first think about it, we think about kind of like muscle health. So it can help with like, if you get tightness or cramping in the muscles, it can help with bowel movement. So if you're constipated, it can help move things along. It helps with headaches. There's so many different formulations that
can help with sleep, can help with joint pain. I think there's like 5 or 6 different magnesiums. I take magnesium malate, which is an anti-inflammatory magnesium, keeping inflammation in your body low. And I take it at night with my progesterone, and I sleep like a little baby.
Yeah. So 3 and 8 is the one that crosses the blood-brain barrier. And so it's really, really great for brain health, can help with sleep. And then glycinate really helps with like headaches and muscle pains. Citrate and oxide are a little bit more intense on the bowel. So if you're really constipated, that's great. but sometimes I do a kind of complex that has a few different formulations of each kind. And that way you're getting kind of all of the benefits, the anti-inflammatory, the bowels, everything.
I
And
use
you
a
can go
company
really
called
high on it.
Designs for Health for my supplements. I don't
Yeah.
know if you can recommend a couple.
Yeah.
It's clean. They use vegan capsules. It's all metabio. But I can't even say it. But clean, great vitamins. So if there's any
Yes.
that you can
Yeah,
recommend,
I think that Designs for Health is wonderful. I use them all the time. Pure Encapsulations is really amazing. Thorne has a great brand. Claire Labs. Those are probably like the four main
right?
supplement companies that I recommend. And, they do third-party testing. They really have good. Metagenics is also really wonderful.
Energetics,
Yeah,
yeah.
yeah.
So the other thing that I want to say that's been out there, you guys, is there's a lot of blood testing kits at home that you can get now. There's a lot of companies opening. I can't say the name of one, but that they do metabolic testing for you and they do things like that. So if you are getting pushback from your doctor and you're looking for a new doctor, do you know anything about some of these home tests where labs are looking at your
So I don't necessarily know about the home test. I mean, I'm sure a lot of them exist. I know that for like menopausal care, if your doctors can't take care of you, there's a great website called MIDI. That
MIDY?
MIDI, and it's for like virtual healthcare practitioners that work specifically in the menopause field. And so it makes it really accessible to, I can't take patients in every state and, I don't accept insurance, but they do. And so we do now have the ability for everyone to have access. So if it's not through your doctor, you don't want to work with someone that's not used to doing this because you want to get the best care for yourself. But there are accessible pathways.
Well, I think we just forgot to mention one thing, which I want to close with, and that's your gut health,
Yeah.
right? Everything starts in the gut. Lauren to mention fiber and that sort of thing. So make sure what you are putting in your body is helpful to you. Make sure that you're conscious of your gut health and you don't have leaky gut and you're looking at your skin, you're looking at your inflammation. But we're here to talk about menopause and again, all of these things are great to address symptoms, but your hormones are the root cause.
Yes.
Hormones are the root cause.
Hormones. And listen, everything you put in your body can affect your hormones. So you're perfectly correct in saying, like, the brain gut connection is really big. And a lot of the kind of leaky gut and the permeability issues can, be increased by this lack of hormones. And so they kind of play off of each other. And so, if you can get food sensitivity testing, if you're having a lot of gut issues and bloating, that could be helpful. They're all different pieces to the puzzle. But sometimes we're here to talk about hormones. Sometimes you can just correct the hormone aspect and those other symptoms will disappear. And if they don't, then you have the ability to go down the other roads of getting all of these other
Peptides.
tests that give us,
That's right.
you can do the gut microbiome test, you can do food sensitivities. We do metabolite testing to look at minerals and vitamins. But sometimes if you just fix the hormone component, especially if it came after menopause, then you can do it. And then just think about the most inflammatory foods as being your dairy products and your gluten products. So, if you're worried about bloating and things like that, you can always try an elimination diet, cut out the dairy, cut out the gluten. Don't replace it with gluten-free products. They're usually worse for you. Just cut it out and see if that helps. And if not, then you can go down and look at all of these other tests.
This is amazing. I thank you so much for helping me open this door. I feel so lucky, you guys, because I have you, everybody else gets you. And so let's let people know where they can find you if they'd like to come directly to you and source all of this through what I consider a plus plus service, the best at Ben Health with you. And then we've given you a lot of other leeways and doors to find your way and your path to your longevity, your good health, and you deserve it. And so, I think it's important. So tell them where they can find you, Lauren.
So I'm in Florida. The practice is called My Vent Health. You can get me on Instagram at My Vent Health or my website, myventhealth.com. You do need to be located in Florida. So if you come here to visit, we could do telehealth. I do home concierge visits. And I would love to work with all of you. And if not, feel free to reach out to me on Instagram. I'm happy to try to, help locate some of these different companies that we've talked about, because everyone deserves to know about this and everyone deserves access to it. So if you can't work with me, I certainly want to make sure that you can work with someone, because this is going to prevent chronic disease. And let's live that last 1/3 of our lives in a healthy capacity, because who wants to live long if you're going to be in a wheelchair and shriveled up, like you said?
Exactly. We're not prunes.
Yeah, we
so
don't want to
keep
be
them in the
prunes.
can, right? So
That's
I
right.
love it so much. Well, thank you so much, Dr. Lauren. You guys read up on the peptides. They're out there. I call them the new vitamins, because they're literally, like, for me, vitamin D, vitamin C, the things that I take. I mean, I've been taking vitamin C even for skin, looking at that new pathway with my skin health. So it all comes down to you, what you need and what you believe is in your reach. It really, really is. And if you feel like it's out of your reach, Dr. Lauren is here to send you in the right direction. Please contact her on Instagram and keep tuning in, because she's a recurring guest with me, and I keep having other experts on to kick these doors open, because these are not secrets no more.
I love it. Thank you so much for having
Well,
me.
thanks everybody for tuning in. Lots of love to you. I'll talk to you soon, and we'll be back again with a new episode coming at you. Thanks, everybody. Thanks for being here today. My true hope is that each podcast gives you some new perspective, new information, or connection into living that brings you closer to your freedom. And I can't wait to meet you here again for more practice next week.